think we're here today to try and inform as many veterans as we can. We're here with Dr. Bash.
Welcome, Radio Land, TV Land, and YouTube viewers and listeners. This is Dr. Craig Bash. I've been doing veterans medical opinions for 30 years, and I have dozens and dozens of these radio shows which we're going to publish on this YouTube channel, and number 1 through whatever. So thank you for listening, and here we go.
It probably makes a lot of sense. Makes a lot of sense because I know a lot of those guys got their fruits and vegetables and they got their water and all that stuff from the shore, right? So this stuff was probably in the ships anyway.
Yeah, but they shouldn't be making other veterans pay.
Right, I agree with that.
You know, if they've determined that, yes, indeed, the Blue Water Navy was exposed to Agent Orange, and then the VA should pay it up. They shouldn't have to go around with a tin cup and a hat to the other veterans that, been awarded benefits and taking money from them.
Trying to offset the cost.
Yes.
Right. They've never done that. Before. They did a lot of Agent Orange cases. They try and take it from other veterans. They should just pay for it.
Well, yeah. They should just pay for it. If
that's fine.
If they're
that's fine
for Agent Orange, then pay for it.
Right. That passed the House, he said.
Yes, it has passed the House. We'll see how it does in the Senate, but it has passed the House. And I was surprised that some of them congressmen didn't bring up the issues of that. If they were exposed and the VA admits they were exposed, then the VA should pay.
Right.
But I think if it does get through the Senate, it'll be the beginning of a big deal like that. Next thing comes along, they'll do the same thing. Once they start getting rid of it or getting away with it. But anyway, back to your chart here, Doctor.
Hey, another reason to appeal 100% is to make sure your dates of claim are right. Right. A lot of times the VA will give you effective dates that are half what they're supposed to be, or third, or something like that. So
yeah,
you just get 100%.
Yes, or a year. It's quite a deal. And on these CMP examinations, there ain't very many veterans get an honest CMP examination. And as you know, I imagine a lot of your work is offsetting the CMP examiner.
That's one of the first things.
Yeah.
That's one of the first things I ask for is a CMP exam, because oftentimes they're done by nurse practitioners or PAs that, PA nurse practitioners aren't even as old as the veteran's claim is. His claim might be, 30 years old, and they don't even have the same experience to cover. These cases are complicated. These cases they might go back 20 or 30 years and involve multiple different diagnoses over time and different testing that's changed over time. And so, in the CMP, oftentimes just ask them to look at one issue. They don't ask them to look at the secondary or tertiary issues we just talked about. And the CMP guy, the nurse practitioner, is not going to change the diagnosis because they have wrong diagnosis through there. So I spend a lot of my time trying to correct those, CMPs. So I'll say that I agree with this part of the CMP and I disagree with that part, or I agree with this part and I disagree with that part. So I can go through and try and be a referee on these cases. Most of the veterans, I think a lot of the CMPs are biased against the veteran. I think that's right. Yeah.
I agree. I think they are biased against the veteran. Would it pay a veteran, or will they allow a veteran to take a tape recorder with them?
Well, I always tell in my Bash Bulletins, I always say take a witness if you can. Take your wife or take your caretaker with you. Document who it was, doctor, nurse practitioner. Number one, document how long the exam took. Trying to see if the doctor or whatever read your file before you got there, so you have an idea what their preparation is. I don't think they, sometimes I've had patients go into CMP and they won't let any witnesses, and I never actually had a patient go with a recorder, but I imagine they may or may not allow that. I'm not sure what the rules are.
I'm not either. I was thinking my next CMP I'd take a tape recorder, because what they tell you and what comes out in the paper is two different things.
I've had some patients that go to exams now, or any kind of medical record, and what they'll do is they'll just wait. They'll say, okay, I want to see a copy of my report before I leave here. And they make them give them something before they leave so they can validate what they said is what was recorded. Because, you're right, a lot of times the CMP...
You need to get a smartphone. You need to get an iPhone, put in your computer when you walk in there, hit that recording button, let it stay on.
Oh, yeah?
Yeah.
Well, I ain't got no smartphone. Ain't even got a telephone.
You can borrow one. You can download it to your computer, too. In a hurry.
Well, yeah.
MP3 format. We'll make a show out of it.
Well, I can see it being an issue, and I know I'm not the only veteran that had these problems. They tell you one thing, and now everything's on a disc, so you're not able to see what they're looking at. And because it's in their computer. So if you tell them something, they start typing. You don't know what they're really saying.
Right.
But you did bring up a good point. You can ask them to see a copy of that report, because they've typed it up and it's on the computer. It'd be no problem for them to run you off a copy.
Right. I've had my patient do that and just sit there and say, he sits there and makes them fix it before he leaves.
Well, that's a good idea.
Yeah. Garbage in, garbage out, right?
Yeah. That's true.
So something else to think about if you have 100% is make sure you have SMC codes. So the VA goes above 100%. I call it 300% up to maximum SMC, but special monthly compensation code. So that's another reason to appeal, spinal cord or TBI, neurologic MS. All those SMC codes are important to make sure.
There's a caveat there, Dr. Bash, on those higher level SMCs.
Yeah.
I mean, you can have it. You can be 300-400% as long as you, if you don't have the need for aid attendance. Aid attendance is the big kicker. The SMC-L.
Right.
That's the one that puts you over the threshold to the higher levels. If you don't have L, then it's aid attendance is the biggest issue there.
Yeah. No. I understand, but a lot of veterans don't really understand all those different codes. So they all stop at 100%, but some of them might be eligible. A lot of my patients these days that come to me, TBI guys, spine, MS, are eligible for, loss of legs and bowel bladder SMCs. They don't understand it. So SMC is a big issue for them to. And it's tricky. I understand it's got stop gaps and stuff in there. But it's something to think about.
And don't they consider foot drop as loss of use?
Yeah. See, the foot drop, the loss of use. I had a veterans judge talk to me about that one day, because a lot of us think about loss of use as just being in a wheelchair, right? But the veterans judge said that loss of use can be due to like neuropathy and balance issues, especially if the person is having falls. And so foot drop falls in that category, because a lot of patients with foot drop have a lot of falls, and a lot of veterans don't want to talk about. They're stoic and the wife said they fell and broke her wrist or ribs or whatever, and the guy's still, grappling along. So, yeah, so we have to remember the diabetes and the neuropathies and the foot drops, all those things can fall into the loss use category depending on how bad they are.
Well, how would oxygen? Yeah, go ahead, your oxygen. Lung diseases.
What about being confined to a wheelchair where you can't walk and you have to ride in a wheelchair?
Yeah, that's the classic loss of use definition of wheelchair use, And a lot of my veterans, so a lot of my veterans, I tell them if, these guys are walking around with canes and crutches and falling, I tell them, I write an order, you have to have a wheelchair. It's not fair for the veteran to be stoic and falling and have neuropathy and not get credit for his loss of use because he's not in a wheelchair. And a lot of times, back to the CMP exam, if the CMP examiner sees the patient, in a wheelchair in a 10-minute exam, his loss of use is going to be much more likely than if he sees the veteran, walking with a cane or crutches in a 10-minute exam. Yeah, because he doesn't really have an idea, that neuropathy is not well developed, and he doesn't know so much about his falling history and stuff like that.
Hey, what about Meniere's disease?
That's a balance problem. Yeah, I don't know. That gets 100% by itself. Now you're talking about maybe trying to get SMC for loss of use, right? That's right. I haven't had a case like that. It's an interesting thing to think about. You could argue. That the guy's got
there's a first
form of neuropathy. What's that?
There's a first time for everything.
Yeah. No, I'm not discounting. I'm just going through the thought process. So you could argue that the person has, neurologic problems.
Right. See, I'm talking Meniere's due to spinal cord, like a spinal cord injury.
Oh yeah, so you get balance problems. Yeah, right. So if you have balance problems, you're falling. That could count. Yes.
Oh, okay. That's a good idea.
Yeah, that's my idea. The guys got pushed back on that, of course, of doctor battle, but that's okay.
That's all right. I know a good doctor that can write an IMO.
Yeah, right. Fight the battle. I don't mind pushing the VA to think outside the box, because the code, the reading schedule is only 2,000 codes, and we have 65,000 codes in regular medicine. So there's going to be a lot of gray area in there. Some of these things will fall into that category.
Okay. What's your take on this new VA ramp system for these appeal process?
Oh yeah, the ramp system. You guys somebody want to explain ramp system to the audience, and I can weigh in, or how you want to tackle it?
Do it Dr. Bash style. I like it. I like your style.
All right. So the ramp, I don't like the ramp program. So I know there's 400,000 wait list at the BVA, and I know that the ramp program is promising to decide the cases quicker for the veteran. But the problem is when you start reading the fine print, the second appeal on the ramp program does not allow any new evidence to be admitted. So basically what happens if they deny it the first time, you get a second look at it, but the second look only gets to look at the evidence the first guy looked at. So then you're back in the same boat as that pathologist. If the pathologist makes a mistake and the second guy just says that mistake's right, then it just rubber stamps it. So you get two denials, so then you're back in the same boat, back to the BVA. And luckily at the BVA, I think they said that new evidence could come in. So, that means my letters can come in, but I think every veteran that has an appeal should be allowed to bring in new evidence if they have new medical opinions, because that's really important stuff that can decide the case. So I don't like the ramp because it shortcuts. It makes the VA's job a lot easier because there's nothing else new to look at. But it hurts the veteran because the veteran doesn't have any new evidence to help support his case. So new lay letters, maybe a new X-ray, maybe pathology report, maybe they find some new pathology from that Fayetteville guy that was wrong. They can't even bring that in on the ramp program. So I think it's bad. Dr. Bash style.
Okay. Where do you want to go next here, Dr. Bash?
Well, I got another one on my list here. I got number 8. What's number 8 say? Oh, just the idea that permanent total. Permanent total, that suffix is not permanent. It's not total. It's not permanent. So the veterans just need to know that those aren't permanent codes for 10 years and 20 years. So if they have some irregularities in their code, they shouldn't just rely on the permanent total. A lot of guys get permanent total and they go to sleep for a couple of years, and all of a sudden the VA comes back and cuts them. They go, "What's this about?" P&T.
Well, the permanent total wouldn't that lock the veteran in on the disability?
No, it doesn't. It just is a designator that lets them get benefits like for, free property taxes, and they get benefits for the children's colleges and wife medical stuff like that. But they can change that permanent total anytime they want to. Up to 10 years they can't change the code, and 20 years they can't change the percent. So any veteran needs to know, and any of those permanent total codes can be relooked at anytime they want to.
Oh, I see.
Yeah, so it's important for the veteran to know that, so that he doesn't, he might have secondary conditions. Like a guy might have, like you talked about, renal failure. You might just overlook it because he's 100% already. But if you knew that permanent total wasn't permanent, you might go back and put a secondary claim in for kidney failure, for example, and protect himself. So it's just good to know that permanent total is not permanent. It's confusing, I know. Well, number 10 is...
Go ahead, Doctor.
Oh, yeah, number 10 is CUE. So a lot of times guys will have a case where they might have 100%, and the VA says, okay, we'll grant you 100% as of 5 July 2018. And the veteran might want to go back and say, hey, wait a minute, you guys made a mistake. Let's go back to that pathologist. That pathologist might be a CUE someday. Hey, wait a minute, that pathologist made a mistake way back in the day. And, my case should go back to the date the guy made the mistake or whatever, So the CUE could be a big deal to them for retroactive benefits and codes, but something they might want to pursue even if they're 100%. Especially the VA. You can make a point that the VA knew that pathologist was impaired and they kept using him. Then a lot of those old cases that he decided could be clear error, they could be clear administrative error on the VA's part. They shouldn't have been using that pathologist, maybe. It's a lot of legal stuff in there, but I can see that there might be cases that could go backwards on that in those areas.
Dr. Bash, I believe your sidekicks made it.
Which one? Tell me which one?
Area code 925. Is that California?
925. Oh yeah, that's Alice. Is Alice on there?
Alice is here. Can you hear me?
Hey, Alice. Yep. So Alice is my executive assistant. She helps me process cases and kind of brokers cases to different people. And so a lot of you guys, if you work with me, you might end up talking to Alice about different stuff. Alice might have some questions for us too along the way.
I do have one question for you.
Yeah.
This just came up the other day. If a veteran's putting in a claim and he gets his everything's done, they did the C&P exam and he gets a negative C&P exam, would it be more would it be more to his advantage to have contract another letter to dispute the C&P's negative report, or wait for the decision and then go back and file a notice of disagreement with him?
That's a good question. You know me, I never want to wait. I don't want to wait for these cases. But yeah, so that's two ways to go, two strategies. Usually if I get a copy of the C&P report and it's wrong, then I'll just say that the C&P report's wrong or challenge it based on x-rays or whatever and go back, and that could be like a reconsideration because they could see that the C&P was wrong. Or, sometimes that triggers a third and fourth C&P, and then they start reviewing my work and review the other doctor's work, and then one of the VA doctors tries to referee that. The problem is if you wait too long for the decision to come out, it might be months or years or weeks, who knows where it is. But if you wait for that decision to come out, then it's even harder for me sometimes to overrule that or change it because I got to change the C&P and then also have to change the mind of the rater, trying to convince him that I'm right and the C&P guy's wrong. So sometimes in cases like that, I might have to get another doctor. I might have to get two doctors to decide on my side if they agree, and then we can challenge it. But yeah, so once those decisions, you also have pride. The rater has pride. Sometimes the raters might get dinged for making an error. So the rater might have a lot of reasons not to change his mind, even if the evidence is overwhelming on the right side once he's written it down.
Mhm. Right. It's the same principle as anybody that's made a decision. It's a lot harder to turn that decision around than it is to catch it before that final is made.
Right. That's a good question.
Yeah. Okay.
Then another reason that patients might want to challenge 100% is, like we're talking about a little bit, psychological satisfaction. They might want to say that a lot of patients don't even care about their rating; they just care that they got credit for being a Blue Water Navy, like you're talking about. I was exposed to Agent Orange and Blue Water Navy, and they want that satisfaction of having that decision in their favor, even regardless of what their percent is. And that also goes back to that thing Alice was talking about, where once again you might want to put a CMP or a second. My DBQs are basically a CMP, so you put a DBQ in to challenge the other CMP to help the patient get satisfaction out of their decision or whatever they want from correct diagnosis and code.
What's your thought on those DBQs, Doctor?
What's that? What was your question?
What's your thought on those DBQs?
Well, I never used to like DBQs, because I used to put the DBQ right in my letter. Basically, I do the exam and put it in my letter. Yeah. And the DBQs are cumbersome, and they're, they got this ACE program where you can talk to the patient on the phone, and some states don't like that. They want you to see the patient, for state licensing, and the federal rules. There's a challenge between the federal rules on medical care and reports and the state rules. They just decided federally about the medical record, where they could say that, they actually decided so that doctors can make decisions across state lines for veterans in some places, And some states now are allowing multiple state licenses, so you have a state license and it's good in several states. So the DBQ crosses some of those lines because the DBQ is kind of a medical record summary, a little bit of medical exam. It might be done for a patient in Kansas, when I'm in Maryland, or California for somebody somewhere else. So, it's a lot of gray area there. So it puts the doctor a little bit of liability for, the rules between the state and the federal. But beyond all that, the DBQ now is a good way that I can challenge if it's incorrect, and challenge the CMP exam by a nurse practitioner or a PA or some VA doctor, and I can order X-rays, I can order endoscopies, MRI scans, and use those things and weave those into the DBQ as part of the workup. And so, and the VA is used to it now, and everybody's kind of used to doing them, so it's becoming kind of part of the whole application process. Basically, anybody that has a new claim probably should have DBQ. Some of the older claims, the patient already has a DBQ, but then they need to have the nexus letter. So some of those patients I won't do DBQ, I'll just do a nexus letter because that's all they really need for step one, with the VA.
It's a complicated issue.
Yeah.
All the way through, and it's getting more complicated, I believe.
Yeah. Yeah.
So, are they going to be adding more presumptive type claims, or are they going to be taken away? It sounds like they're trying to combine different issues instead of handling them independently.
That's right. So they might take some presumptive diagnosis and lump it with a couple others and give the guy a rating. So, and the raters love to do that because it gets it off their desk, right? If they can lump 3 or 4 cases together, give them a presumptive code, and see them, send the case out, that's less work for the rater. So, I don't know what the strategy is about numbers of presumptive diagnoses. I imagine over time, in my lifetime, they've added presumptive diagnosis every year or two. So.
Well, that's not good. So that means the veteran has to get a little bit more wiser, or quite a bit more wiser, before he tackles this VA. He's got to go in with some professional help.
Yeah, those lump codes are really confusing to the veterans. You know, even on the coded rating sheet, I don't think they break them out. So I think that any code that you're rated for should have a rating. Any code that's lumped should have a rating, a separate independent rating for that code. That's the only way to do it, because otherwise they lump them together and you don't know what's going on. They're doing a lot of that. You know, some guy will have 12 cases. They'll lump 4 of them together and give them 3 codes and close the case. You know.
Oh man. Then take forever to get that squared away again.
Yeah, because you don't know exactly what they rated you for. It's muddy water, right?
Well, it must be. I think they have a code, a stupid code they use. Yeah. So, yeah, I don't know how in the world the VA's not getting any easier to deal with. So it takes people with your type of expertise to help get them through the maze there on the medical side of it. Because, like the poor veteran, he ain't going to know if they combined a whole bunch of stuff. Give him 10% and tell him how lucky he is.
Right. And the admin side's hard too. That's where Alice comes in, because she can help them work through some of these issues too, because you have the intent to file. You know, you've got these ideas about whether they do a ramp program or not. You know, there's a lot of issues that we can help with both sides of the fence.
This almost calls for special schooling just to get through the VA.
Well, that's what I tell my doctor buddies. You know, if somebody wants to do veterans cases, it's you know, medicine's hard enough, but then the veterans law on the other side takes several years to kind of work out what's going on, and it's always changing too. So it's almost like a whole new training program doing these veterans opinions, because there's so much on the law side that has to weave into the medical opinion.
Thank you all for listening. That ends this show. And now I'm going to zoom off.